All right, it's 7 a.m., so let's go ahead and get started. Today's theme seems to be related to trauma surgery, and the first speaker this morning is Tom Schroeppel, who comes to us from Colorado Springs, where he's the trauma medical director at Memorial Central Hospital. He's a clinical associate professor in the Department of Surgery at University of Colorado, but he began his medical career by getting his MD degree at the University of Minnesota before he went to Gunderson to do his general surgery residency, and then he migrated to the South to go to the Elvis Aaron Presley Trauma Center. Isn't that the name of the trauma center at the University of Tennessee in Memphis, where he did his trauma and critical care fellowship training before he joined the faculty at UT Memphis, I think in 2007, and then he was recruited here to take over the trauma program at Memorial Central in 2016. And then in the big milestone there was that he was able to lead the effort and successfully accomplish Level 1 verification by the ACS and designation by the State Department of Health as a Level 1 trauma center at Memorial Central. And this morning he's going to talk to us about beta-adrenergic blockade and traumatic brain injury. Tom, thanks for coming.
Thank you, Dr. McIntyre. It's a pleasure to be up here and give this grand rounds on a topic that actually has been interesting to me for over a decade now. How many of you have been familiar with this topic in the past that are in the ICU? To use propranolol or beta blockers in the ICU? Oh, great. I see a lot of hands up. I love to talk to a crowd that actually shares my bias. So our objective today is identify what's dysautonomia, which that's one of about 12 names that go for it: paroxysmal sympathetic dystrophy, sympathetic storm, sympathetic surge, any of a number of names. We're going to summarize some current literature and then assess what role, if any, is there for beta blocker in these patients. So one of the studies I was going to talk about towards the end actually was funded by the University of Tennessee and the Semmes Murphy Foundation. That's the only disclosure I have. So we know traumatic brain injury is a bad problem, affects a lot of folks. It looks like I just lost the projector. And now it's back. And it's a disabling disease. It's not just the initial injury. It goes for an extended period. And leading cause of death in the age of 1 to 44. So it's not just the initial injury. As we all know from ATLS and a variety of other things, you have to prevent hypoxia and hypotension. And then there's further cellular damage that leads to vasospasm, hypoxia, cellular edema, and increased metabolic demand. Catecholamines surge in TBI. Interestingly, they indirectly correlate with GCS, meaning they're higher with a lower GCS. And then as neurologic recovery happens, they get better. So beta blockade has the potential to decrease cerebral metabolism, decrease vasospasm, and decrease cerebral oxygen consumption as some of the hypotheses for how it actually has some beneficial effects. So in the first paper I looked at this back in published in Journal of Trauma in 2010 and determined, if patients get beta blockers, what effect do they have? So we had over 2,600 patients, as with most trauma populations. Most were male, young, severely injured, the ISS at 26, and overall mortality of 16%. 510 in beta blockers, just over 2,000 did not. When you look at this population, who would you expect to get beta blockers? Well, the older patients who are getting them for hypertension. So this population, beta blockers were older. Most were male, as I mentioned, severely injured. And a moderate head injury with a GCS on admission of 10 and a head AS of 4. When you look at outcomes, patients that got beta blockers stayed in the hospital almost 3 times as long, ICU twice as long, much more likely to get mortality, but no difference in mortality. So is there an effect here? Well, we did fancy regression analysis on this and adjusted for a few things. And not surprisingly, age, ISS, GCS, and transfusions all predicted outcomes. But here, beta blockers were significantly protective, reducing the odds of mortality by 64%. We then again went through and actually took out the patients that you would expect not to benefit, withdrawal support and deaths in the first 48 and 72 hours. The effect was then lost. We then looked at Cox proportional hazards to see if a time-dependent variable would help, and indeed it did. So this gave us the idea that perhaps maybe we should be using these more. So as I mentioned, despite higher age, there was no difference in mortality, and it was an independent predictor of survival after adjusted analysis, and maybe it does work. So that brought us into, well, if beta blockers work, is there one that's better than others? So this is a study that I published in 2014 and presented at the AAST looking at beta-blockade and maybe the type of beta blocker. So similar population. This was the next 2 years after this. And again, classic with most trauma studies, young males, severely injured, and overall mortality 16%, almost identical to the previous study. We looked at this population, 611 got beta blockers, 2,000 didn't. And when looking at this again, you'll notice here that this is almost identical to the first chart I showed. Patients were older, as you would expect for those that got beta blockers. Most were male, severely injured. When looking at length of stay, again, this is almost identical to the first study. I promise these are different slides. But in the overall in the hospital, almost 3 times as long, ICU 3 times as long. But again, no difference in mortality, which is interesting. So there's definitely a signal here. And when doing the regression analysis, here beta blockers again are significantly protective. So we then went and looked at what type of the beta blockers. So 611 patients that got beta blockers. So a lot of us bought into it at this point, and it was my own bias that propranolol is perhaps the best beta blocker. 1, it's cheap. 2, you can give it oral. And 3, it's been proven in other populations such as burn and cardiac. And if you look at that, 82 got propranolol because we had bought into it and started to give the propranolol, and then 529 got other beta blockers. Now, I want to point this out to you. When you look at this chart, this is the first time you see that the actual age is much less in the patients that got beta blockers. So maybe we're actually selecting out the patients we actually want to treat. So these are the ones with true dysautonomia after head injury. Otherwise, the chart looks very similar, with the exception now that the head AAS and GCS is much lower in those that got beta blockers instead of roughly equivalent. Then looking at outcomes, again, overall length of stay longer, higher ICU length of stay, and a huge benefit in mortality. So this is really interesting. And then when we did our adjusted analysis, propranolol decreases the odds of mortality by 93%. And the adjusted analysis, now this is excluding patients that were likely not to benefit, so those that died in 48 hours or either a minor or a very severe head injury, beta blockers did not show a benefit, similar to that first study I mentioned. But propranolol does still show a benefit, reducing the odds of mortality by 80%. And then we did the Cox proportional hazards analysis. Those confidence limits are a little bit wider, but still a benefit here, still a signal. We then did a Kaplan-Meier plot, and you can see those curves start separating very early and then maintain an effect all the way out to about 120 days. So in conclusion, again, similar to the first study, patients had benefit with beta blocker, and propranolol patients were younger. And actually, these are the patients that I think would benefit the most. And maybe propranolol is the best beta blocker for suppression. This led into a study published last year that I participated in by Eric Lay out of LA. And it was presented at AAST, very similar to the other ones, but this was a prospective observational multi-institutional trial. They looked at beta blocker compared to no beta blocker, outcomes 30-day mortality, and they added a functional outcome, the Glasgow outcome score, and then also did a subgroup analysis looking at propranolol as compared to other beta blockers. So they screened just over 2,000 patients, and they were able to analyze just over 1,100 in both arms. And when looking at this, similar to the first 2 studies, at least on the initial part, patients that got beta blockers were older, most were male. These numbers were much larger, so obviously you see a lot of things that are clinically significant here, but not necessarily clinically relevant. When looking at the results, you can see that patients that got beta blockers were worse head injury, and most of the injuries are about the same. Again, these are a lot of statistically significant because they're large numbers, but not necessarily clinically relevant. Treatment of hypertension, like I mentioned before, is consistent with this study. Interestingly, they used a labetalol IV more in this study, but it wasn't restricted. So any beta blocker counted. But propranolol was up there. PO is what I like to use, and that was 28%. And then when looking at mortality, it was definitely less in the beta blocker group. And they also did an adjusted analysis, and the odds ratio was 0.35. When looking at propranolol as compared to others, there's an even stronger effect. With the adjusted odds ratio of 0.35, the mortality was reduced significantly. And then looking at Cox proportional hazards, this is beta blockers to no beta blockers, hazard ratio of 0.42, so significantly protective. And then looking at propranolol as compared to the other beta blockers, you get an additional protective effect with a hazard ratio of 0.5. So in conclusion, with all these 15 institutions, their survival of benefit was noted for beta blockers and more profoundly for propranolol. And that led to a randomized trial I was already doing at Memphis at the time. This was ongoing actually up until just last year. And I just presented this actually at Saturday at AAST. So this was the one that was funded by the grant. I wanted to look at the effect of beta blockers mortality in patients, and then also look at the ability to suppress catecholamine surge by tracking urinary catecholamines. And the third effect was to look at healthcare disparities in the outcomes in patients with TBI. And this manuscript actually is under review currently at the Journal of Trauma. So we included adults with an isolated TBI as defined by GCS less than or equal to 12, an injury on head CT, and AS less than or equal to 3 from other body regions. I had to redesign this study several times because a couple of things I noted. One, it's really hard to do a randomized trial, as you'll see when I talk about the enrollment. And two, I set the inclusion criteria so strict it was hard to ever enroll anybody because you don't see isolated TBIs very often. There are my exclusion criteria. It was unblinded because you know what happens when people get beta blockers. You're trying to block them down, so there's no way to blind it. And we did pseudo-randomization because we thought the numbers would be small just to ensure equal assignment to groups. Obviously, a propranolol and then a standard therapy. We gave propranolol orally. It was cheap. It was easy to do. And we actually titrated it. One of the weaknesses of the other studies that I mentioned is none of the beta blockers were titrated. They were given or they weren't given. I actually wanted to titrate them to see if we could actually have an effect. Treatment for 14 days, which was one question previously. Why did you pick 14? Well, that was completely random. I had to have something that was objective, something I could study, and something that was in a reasonable time frame. And then the primary outcomes were mortality and urinary catechols. We did repeated measures of a number of different physiologic variables and scores that we'll talk about here in a moment. We did some repeated measures analysis of the variance to account for these paired measurements. So I screened 525 patients over this 24-month period and only randomized 26. I tell you, that was disappointing when you screen for 2 years and you get 26 in your study. 14 in propranolol and 13 in each group. And then, interestingly, one of the patients in the control group's wife did not remember that he took a beta blocker, so I had to take him out of the study on study day 1. So we analyzed 13 in one group and 12 in the other. Similar to most the other ones, most patients were male, 51 years old. They stayed in the ICU in 16 days, overall length of stay, 25 days, and mortality was 16%, which is interesting because that's very consistent with all the other studies. 13 propranolol, 12 in the control group, and when looking at this, the randomization worked. We really didn't have a whole lot of difference between study groups. When looking at payer source, what I found interesting is that in the treatment group, for whatever random reason, a lot had private insurance. When looking at the control group, a lot was more government funded, and there was a significant portion of self-pay, and this was done at Memphis, so that's not unusual. When looking at heart rate, not surprisingly, the beta blocker patients, which you see in blue, had a significantly lower heart rate on days 4, 5, and 6, but then the curves actually overlap again. So it wasn't sustained even though that group got beta blockers. When looking at temperature, there's not a significant treatment effect. When looking at mean arterial pressure, and this is really interesting, the treatment group actually had a higher mean arterial pressure, and that was statistically significant even with a small sample size. So the patients that got beta blocker had a higher blood pressure. Go figure. And when looking at Glasgow Coma Scale score, even though it wasn't designed to actually have a statistically significant, this was done as a pilot study, we did notice a divergence of the curves at day 14. Those that got treatment had a GCS of 11 at the study end as compared to 8, and this did meet statistical significance. When looking at urinary catecholamines, this is the total catecholamines. You can see that curve is divergent again, perhaps suggesting that there's some sort of feedback mechanism that leads to higher catechols and a higher sympathetic storm, although we're blocking it in the patients that actually get propranolol. Urinary dopamine was higher. Urinary norepinephrine was higher. Interestingly, epinephrine was not, and we have a theory about this. Perhaps the central catechols, norepinephrine and dopamine, are higher because that's where the effects are as opposed to peripherally where epinephrine comes from. When looking at the Apache 2 score and the SOFA score, they improved over time as you would expect in patients in the hospital receiving care. So when looking at outcomes, we did not notice any significant difference between length of stay and ICU length of stay. But when looking at mortality, we did notice also a trend or a difference here. Now, there's a caveat with this. Most of the patients that died in this study died from withdrawal support. So I don't know what to make of this, and most of them were actually in the control arm. So while that looks like it's interesting, it's maybe less so than we thought. When looking at Kaplan-Meier, those curves are almost superimposed on each other. And when looking at where they went, there wasn't a difference between groups. So in conclusion, that was a pilot study. It's feasible and safe. I've actually supplied this to Eric Lay, who hopefully is going to get some funding so we can do a multi-institutional trial. Differences, even though it wasn't designed to detect them, GCS at study end, mean arterial pressure, and catechols were all higher in the treatment arm. So this led to my last study that I'll talk about today that actually I'm just in the process of analyzing now. I was on outreach, and somebody said, well, how are your patients doing now? I don't know. How are they doing now? There's really very little data on follow-up after these patients leave the hospital. We all look at what happens in the hospital, but what happens afterwards. So we took this same study, and then we actually did a phone survey and an obit search to find out how those patients that lived discharge in that study actually did after they left the hospital. We compared beta blockers to propranolol and then to no beta blockers. We used non-parametric statistic tests and then used linear regression and survival analysis and adjusted survival analysis with the Cox proportion. Outcome was EGOS, so we actually conducted a Glasgow Outcome Score extended phone survey, and then secondary outcome was mortality. So when looking at these patients, there were a couple of differences between those that we could find and those that we couldn't find. Interestingly, we only found 26%, which actually surprised me. I didn't think we'd find that many for a trauma patient population. The ones that we were able to track down were a little bit older, probably because we found them in the obituaries, so they tended to be older. Their ISS was a little bit less, and when you look at that beta blocker versus no beta blocker, we tended to track down the beta blocker group for whatever random reason. So of the 211 patients we tracked down, similar with most trauma studies, they're relatively young male, they're severely injured. 167 got beta blockers and 28 did not get beta blockers, and 16 got propranolol. When looking at these groups, interestingly, the propranolol effect that I mentioned in that study held, which is not surprising. This is the same data. They were much younger. Their base deficit was higher. They had more transfusions. They had a lower GCS at admission and higher overall ISS and head AIS. So they're pretty severely injured. When looking at outcomes, they stayed in the hospital longer. They were more likely to die than the no beta blocker group, and their 5-year survival was only 63%. Extended Glasgow outcome score of 1 is dead. So as you can see, a lot of these patients died after they left the hospital, whereas a no beta blocker group had an EGOS of 5, which means they're at least able to live on their own and they may be able to shop. 8 is normal. When you look at the regression analysis, interesting here, propranolol, although it didn't have an effect, it predicted a worse outcome. So this is regression for EGOS. So if they had propranolol, they were almost a point lower on their EGOS, which may be just a consequence of the patients we tracked down. When looking at the Kaplan-Meier, the blue line is no beta blocker, and the green and red lines are the beta blocker and propranolol, and you can see those curves are almost superimposed. So when we did the Cox proportional hazards analysis, not surprisingly, age and GCS were the things that predicted outcomes. So in conclusion, the follow-up study did not show a benefit of beta blockers. Now, I think we have to interpret that carefully because obviously we tracked down a lot of the patients who were dead because it's easy to find them. Interestingly, using Dr. Google and obit searches, you can track down a lot of patients where they're published. Injury severity and age are more predictive of poor functional outcome. So as one of my mentors would say, 6 people die. Well, yes, that's what we've proven in this study. And I think there's a significant sample bias in this because those are the patients we track down. So for overall summary, I'm still convinced that beta blockers are beneficial in TBI. I think propranolol is likely the best drug. It's inexpensive. It's easy to use. We use it orally. You don't have to use it IV. I know some other people use it IV. The benefit after the index hospitalization is unclear. Are we allowing these patients to survive till discharge to go to a nursing home and then have some sort of catastrophic event at a nursing home? And I think the answer is unknown for that. We clearly need a multi-center randomized trial, and I think long-term follow-up should be better studied because, there's more than just in-hospital mortality. I think a lot of that's coming out in a lot of the trauma literature. What happens after that index admission? I'd like to thank you for allowing me to present some of my work today, and I'd like to thank Dr. McIntyre. I'd be happy to entertain any questions.
That's a great example of how you do a series of sequential studies to try to get at the answers of questions that the first study raises from the data you analyze. But anybody have any questions? If not, I can start by asking you, what do you think the hypothesis, or do you have a hypothesis to explain why propranolol is better than any of the other agents like labetalol or metoprolol?
My hypothesis is it's the most lipophilic agent, so I think it best crosses the blood-brain barrier. And I mean, that's where a lot of the pathology happens and the pathophysiology in this process. So I think if you can get that beta blocker across that blood-brain barrier, it works better. Metoprolol is not bad, labetalol is not bad, but propranolol is the gold standard in terms of what crosses.
Yes, sir.
Additionally, I think it also got alpha-1 agonist properties as well as 5-HT3 and 5-HT4 properties as well, which explains some of the CNS effects better than the other beta blockers.
Thank you. Another hypothesis.
Another question I anticipate is, your future direction sort of alludes to the point where you think that there needs to be a multi-center prospective randomized trial. And I'm thinking of experiences with other networks where the equipoise ethical issues could be raised in the sense of, is there equipoise to say that you should treat patients with a placebo?
Interestingly, I had a long discussion with the IRB about that when I started this study, and there's no level 1 evidence about beta blockers being better. So by definition, there has to be equipoise. I mean, a lot of us are biased and think it's better based on retrospective and even prospective observational studies, but there, as with a lot of literature, the retrospective data doesn't always hold true when you actually do a prospective randomized trial, and a lot of us are surprised by the results. So after spirited discussion with the IRB back in Memphis, they did ultimately improve the project.
Gotcha. And then the other question I have, which is an argument I have with some of the other faculty here, is if you stratify your patients by some type of severity of sympathetic output. So in other words, just limit the beta blocker to the patient who's tachycardic and hypertensive and seems to be more sympathetic. Does that change the effects of the beta blocker, or should you just be treating everybody with a beta blocker?
The answer is we don't know, and I say we collectively. It's clear when you need to treat the sympathetic patient, but one of the questions that came up from my discussant at AAST was, this doesn't often show up for weeks to months until after the inciting event. So how do you know who you're going to treat? So I think a lot of us have just started treating everybody and putting them on something to try to suppress this, to try to prevent that sympathetic storm down the road. But the real answer is we don't know. We have no idea. I can't give you a better answer than that because I don't think anybody knows. Frank.
Dr. Vogel, just looking at how few patients you were able to randomize when you screened so many, and that one study of the series that you presented, so what suggestions or what did you learn from that you could pass along to people that are starting studies like this to increase the number of patients that you randomize as a percentage of how many you screen?
So there were several lessons there. Lesson number 1 is make sure you set your enrollment window so that it doesn't happen on a weekend, because our study nurses didn't want to work on the weekend. So I had set a 48-hour window. So that means that people that came in potentially Friday morning or Friday late afternoon had a window that ended on Sunday. So that one of the redesigns was to extend that to 72 hours. So that was just a ignorance on my part. The other one I learned was don't set your inclusion-exclusion criteria so strictly. I really would love to study only isolated head injuries. Unfortunately, that doesn't happen very often. So when I started, it was AIS, or abbreviated injury score, of less than 3 in other body regions. Well, as it turns out, a single long bone or a splenic laceration or some of those things puts you at 3 already. So I had to adjust that to less than or equal to 3, which doesn't seem like a lot, but that automatically increased our enrollment by about 30% within a couple of months. The other thing is, I think as a PI, the more you're able to interact with the patients you're enrolling and their families, the more trust they have in you. Because we did have 13 patients and family members who withheld consent. And I think, propranolol, it's been around forever. Why would you withhold consent for propranolol? But, as soon as you say study, a study, I don't want to be involved in that. That's an investigational drug. No way. This is crazy. You're doing experiments on me. Well, the answer is yes, but it's a drug that's been around since the 60s, and once they meet the PI, or at least an SI, and they establish that trust, I think it's a lot easier to enroll patients. So it was a painful 2 years, but I learned a lot. The other thing was to try to do the study remotely, because I finished that study while I was actually in Colorado Springs, and one of my partners worked on it, but it's a lot harder to do that too. It was actually my master's project. I used that randomized trial to finish my master's degree last December. I don't know if that answered your question, but I certainly learned a lot of things about, and the bottom line is study design. A well-designed study will make it a lot easier for you to successfully complete it without having to redesign it.
In the screening to enrollment rate is notoriously low in critical care settings, as opposed to, like, if you have cancer and you're going to get enrolled in a chemotherapy trial in your clinic and you're maybe not critically ill, dealing with a surrogate decision maker or something like that. Screen to enrollment rates in critical care tend to be more like 10%, whereas trials that are outside of the critical care arena tend to be more like 20 to 25% screen to enrollment rates. So that enrollment rate is a fairly typical one when you look at the ICU study population. Any other questions? Frank?
In patients who are on underlying beta-blockade coming in, do you transition to propranolol?
We excluded them. Or you mean currently or in the study? I usually, if they have a TBI, I transition them to propranolol and then titrate to effect. I think that's important. A lot of those first studies I mentioned, it's just whether you got one or not. And the first two I did is one dose, greater than one dose of beta blockers. We excluded for one. And a lot of those patients, you can't. Now, most of them got, 10s, 20s, hundreds of doses. But that's one of the weaknesses of the prior literature. So my practice is to transition to propranolol if they have a TBI, and then up the dose until their heart rate's less than 100 or they become bradycardic.
All right, thanks very much.
Thank you.